We're very honored to welcome Dr. Elyssa Widjaja, I'm going to mispronounce your last name, Widjaja, correct? Yes, who's a pediatric neuroradiologist and the Division Head of Neuroradiologist at Lurie Children's Hospital. She has a clinical interest in pediatric epilepsy imaging and works closely with the epilepsy team, in evaluating children for epilepsy surgery. We don't have a ton of information on our website and on our YouTube channel about the particulars of structural imaging, including diffusion tensor imaging, looking for those connections, and for those of us whose children have had reoperations or may need one, seeing where there are misconnections. So welcome, Dr. Widjaja. Thank you. Watch your step.
Thank you so much for the invitation to present. I'm really honored to be able to present in this conference. So my name is Elyssa Widjaja. I'm a practicing pediatric neuroradiologist with special interest in epilepsy imaging. I've been doing this for the last 20 years. And previously I was in Toronto at the Hospital for Sick Children. And in the last 19 months ago, moved to Chicago to take up the Division Head of Pediatric Neuroradiology position and to work really closely with the epilepsy team in Lurie Children's Hospital. So these are the topics that I will cover in this presentation. We will start off by reviewing the MRI lesions that we may encounter in children who are being considered for epilepsy surgery. And then we will review MRI-negative epilepsy. What does that mean? So MRI-negative epilepsy refers to children with epilepsy who have normal MRI. So in this context, what other tests should we do if the MRI is normal? So we'll talk in more details about that. Next, we will cover hemispheric lesions. So these are big lesions that affect one side of the hemisphere or one side of the brain. And patients with hemispheric lesions will undergo hemispherectomy. Most of you are familiar what hemispherectomy is, but for those who are less familiar with that, this is a type of surgery that fully disconnects the bad side of the brain from the good side of the brain. We will also look at what happens if seizures recur after hemispherectomy. What do we do then? And then in the last part of the presentation, we will review post-processing of MRI for epilepsy surgery planning. So about 30% of patients with epilepsy have drug-resistant epilepsy, which is referred to as persistence of seizures despite treatment with 2 or more anti-seizure medications. The 2 broad categories of treatment for focal drug-resistant epilepsy include epilepsy surgery or medical therapy. So in a previous systematic review of the literature, we have shown that epilepsy surgery in children resulted in better seizure freedom compared to medical therapy. We also showed that children with non-lesional epilepsy, that is children with epilepsy who have normal MRI, they are less likely to be seizure-free compared to children with lesional epilepsy, that is, there is a lesion on MRI. So that is why we spend a lot of time, myself and the neuroradiologist spend a lot of time reviewing the MRI in great details to try and identify a lesion on MRI because it really impacts on patient outcomes. So a lesion can be identified in up to 80% of patients with focal intractable epilepsy. Having said that, the percentages do vary across institutions. So centers that do a lot of epilepsy surgery usually have higher pickup rate of a lesion on MRI compared to centers that do less epilepsy surgery. So what are the types of abnormality or lesions, we call them lesions, on MRI that we may encounter in patients with epilepsy who are being evaluated for epilepsy surgery? The 2 most common lesions are brain malformations. Brain malformations, in particular focal cortical dysplasia, which is a type of brain malformation. It's very common in children with focal intractable epilepsy. The other lesion that is common is low-grade tumors. Other lesions are less common, such as hippocampal sclerosis, Rasmussen encephalitis, which is an inflammatory disorder that affects one side of the brain, cavernoma, which is a vascular lesion, and Sturge-Weber syndrome, which is a congenital anomaly that usually affects one side of the brain. So I'll spend a fair bit of time on focal cortical dysplasia because this is one of the most common lesions in children with drug-resistant epilepsy. It is also one of the most challenging lesions to detect because the MRI features are frequently subtle, they are small, they are difficult to detect and easily overlooked on MRI. So why this emphasis on trying to detect a lesion, in particular focal cortical dysplasia? If we can detect focal cortical dysplasia or detect a lesion on MRI, you can potentially improve the success of epilepsy surgery in achieving seizure freedom. So finding focal cortical dysplasia, as I mentioned earlier, is really challenging because it's small, it's subtle. You know, it's almost like trying to find a needle in a haystack. So when I see a report, particularly if patients have been referred to us and the report says normal MRI, the first question that I ask myself is usually, is this truly a normal MRI or is there a really subtle focal cortical dysplasia that is easily overlooked on the MRI? So in a previous study, we reviewed the MRI and also the surgical outcomes of patients with a really subtle form of focal cortical dysplasia. We have found that many of these lesions are frequently overlooked because they're really small, and trying to scroll through 1,000 images, it's very easy to overlook this type of lesion. So it's really important to have experienced neuroradiologists to review this type of MRI in order to pick up these subtle lesions. So thinking more broadly, what are the types of factors that will affect our ability to identify a lesion on MRI? So the types of lesions do matter. So focal cortical dysplasia, as I mentioned, can be subtle and easily overlooked on MRI. On the other hand, low-grade tumors, they're much easier to detect on MRI. Other factors that influence our ability to detect a lesion include the types of MRI scanners and the techniques, and I will go into a little bit more details later on, and the experience of the epilepsy center as well as the experience of the neuroradiologist. So let's start off by looking at the types of MRI scanners. So most clinical scanners use these two types of scanners, 1.5 Tesla MRI or 3 Tesla MRI. So what do these refer to? This refers to the strength of the magnet, with higher Tesla representing more powerful magnet, and you can do higher resolution imaging with stronger magnets. So Dr. Winston and colleagues in London, UK previously have shown that when they repeat the MRI on a 3 Tesla magnet, they were able to identify more lesions compared to 1.5 Tesla magnet. So as an example of a case, so this patient presents with focal epilepsy. Initial MRI that was done on 1.5 Tesla magnet did not show an abnormality. So I reviewed this MRI, I couldn't see an abnormality. We then repeated the MRI on a 3 Tesla magnet, and we showed a really subtle lesion on the left side of the brain. So in addition to the strength of magnet, the MRI protocol also matters. So what do I mean by MRI protocols? So usually when we do an MRI, we do what we call by different sequences so that you obtain different signals of the brain in order to try and characterize the brain further and characterize any lesion further. So for epilepsy patients, we would typically do dedicated high-resolution epilepsy protocol that are much more detailed and higher resolution compared to standard brain protocol. In that way, we can then detect lesions that are subtle on the epilepsy protocol. The other factor that affects our ability to identify a lesion is the expertise and experience of the radiologist. So typically, specialist neuroradiologists will detect more lesions compared to non-specialist general radiologists, and specialist neuroradiologists with experience and expertise specifically in epilepsy imaging will also identify more lesions compared to neuroradiologists who subspecialize in other areas other than epilepsy. So to show an example in terms of the resolution of the scan, how it affects lesion detection. So the top two images in the top row, they are slightly lower resolution. They're still high quality imaging, but slightly lower resolution. When we reviewed the MRI, we could not see a lesion on the MRI. Because the patient has really focal epilepsy, we repeated the MRI with high resolution techniques, and we were able to see really subtle abnormality on the left side of the brain, which I've circled here. So you can see it's really, really subtle and small. So in addition to the MRI, the types of scanner, the MRI techniques, and the experience of the radiologist, the other factor that influence our ability to identify a lesion is the age at which the MRI is done. So typically the brain undergoes maturation, and there's a lot of changes because of the brain maturation process going on, particularly in the first few years of life, typically in the first 3 years or so of life. So on this slide, I have shown 3 images. So you can see that at 12 months of age, there are more bright areas in the brain. And then as the child grows older, there are more dark areas in the brain. This is just part of normal development, part of normal brain maturation. Because of the changes in the brain on imaging, it is not surprising that the appearance of focal cortical dysplasia also changes with age. So in this child, the first MRI, we could not see an abnormality. I put an arrow there to indicate where the lesion was subsequently identified later on. But you can see that at 19 months of age, there is a lesion identified, and at 5 years of age, there is also a lesion identified. But on the first MRI at 12 months of age, we could not see the lesion. So this is another case to show how the appearance of focal cortical dysplasia can change over time, particularly in the first 2 to 3 years of life. So the first image on the left is when the child was 8 weeks of age, and you can see the lesion really well. Like you can see a dark area that represents the focal cortical dysplasia when the child was 8 weeks of age. However, at 5 months of age, the lesion was less obvious, it's less conspicuous, simply because of the changes in the brain maturation, altering the signal intensity of the brain. So because of that, there is a term that we use, sometimes we call it the disappearing focal cortical dysplasia. It's not that the focal cortical dysplasia has disappeared, it's simply because of the changes in the signal of the brain from the brain maturation that it becomes less obvious at certain age group. So in particular, from about 6 months of age to roughly about 2 to 3 years of age, where it may become less obvious. Okay, so let's move on to look at MRI-negative epilepsy, which refers to children with epilepsy with normal MRI. So the International League Against Epilepsy has recommended that additional tests in addition to video EEG and MRI should be done for specific lesions. So those specific lesions include focal cortical dysplasia or other scenarios such as patients with MRI-negative epilepsy. So what are these additional tests that they recommend? They recommend that one of these tests should be done, such as magnetoencephalography, SPECT, or PET scan. So usually the SPECT and the PET scans are we display in colors to help identify kind of subtle changes in the metabolism or perfusion of the brain to help us identify subtle abnormality. Okay, when we do the PET scan, we typically combine it with MRI so that it helps us really identify the exact location of the PET abnormality in reference to the MRI. And we can also re-review the MRI based on the PET abnormality. So it kind of serves as a dual function. So if we can re-review the MRI, some of which may be abnormal, and we want to correlate that the PET abnormality corresponds to where the MRI abnormality is, or if the MRI is considered normal, we will go back and re-review those areas specifically, look at it in further details to see if we can find a lesion there. So Dr. Salomon and colleagues have shown that when they combine the PET with MRI scans, they can improve the detection of focal cortical dysplasia, because knowing where the PET abnormality is, they can then go back and re-review the MRI to see whether there is a lesion. So previously, when I was in Toronto, we've changed our diagnostic imaging practice for epilepsy surgery evaluation. So we've changed from 1.5 Tesla MRI to 3 Tesla MRI for all epilepsy patients. And we also included PET to MEG, i.e. we do two of those tests in patients with normal MRI. So we then assess how this change in practice affects surgical outcome. We showed that following the change in practice, there was an improvement in seizure-free surgical outcome, emphasizing the importance of really good MRI techniques and the inclusion of one of these additional tests, PET, SPECT, or magnetoencephalography, in those with normal MRI. Okay, we will move on to the next section, which is hemispheric lesions and hemispherectomy. So hemispheric lesions are big lesions that affect one side of the brain. This could include brain malformations, i.e. huge focal cortical dysplasia, hemimegalencephaly, which is a big brain malformation that affects one side of the brain, a previous large stroke, Rasmussen encephalitis, which is an inflammatory disorder that affects one side of the brain, and Sturge-Weber disorder, which is a congenital anomaly that affects one side of the brain. So in a previous systematic review of the literature, we have shown that amongst the different types of epilepsy surgery, hemispherectomy yielded the best seizure-free outcome rate compared to temporal lobe epilepsy surgery or extratemporal lobe epilepsy surgery. However, not all hemispherectomy will achieve the same seizure freedom rate. If one of these factors is present, then the seizure freedom rate will be lower. So what are these factors? If the seizures occur earlier in life, if there's generalized seizure semiology, if there is bilateral PET abnormality, if there's non-stroke abnormality, and previous history of epilepsy surgery prior to the hemispherectomy. So if any of these factors are present, then seizure freedom rate is somewhat lower compared to if these factors were not present. So what happens if a child develops recurrent seizures after hemispherectomy? So typically a video EEG will be done and an MRI will also be requested for. For the MRI, we would typically do high-resolution structural MRI and diffusion tensor imaging to look for residual connections and other findings. So let's go through in more details. So the top two images are structural MRI in a child who has had hemispherectomy on the left side of the brain. And the bottom two images are what we call by maps that are acquired from diffusion tensor imaging. So both the structural MRI and diffusion tensor imaging are done to look for small residual connections that are still joining the two sides of the brain. So joining the bad half from the good half with the good half. And they're typically located in the front part of the corpus callosum, and we'll review what corpus callosum is. So I wanted to emphasize that you can see that the remnant tract, they're really small. They're usually like 2 to 3 millimeters in thickness, so they're by no means like huge. Therefore, we have to do high-resolution imaging in order to find this type of small residual connections. So, as I mentioned earlier, they are typically located in the front part of the corpus callosum. So, what is the corpus callosum? This is a large bundle of nerve fibers that connect the two sides of the brain. So, think of it as a bridge that connects the right and left side of the brain. So, this is another example of a patient who had hemispherectomy on the left side and developed recurrent seizures. So the top two images are the high-resolution structural imaging, and the bottom two images are the diffusion tensor imaging. So again, you can see from the arrows, there is residual connections, and the residual connection is really small. It's somewhere in the order of 2 to 3 millimeters in thickness. In a previous study, we evaluated the outcomes of patients who had recurrent seizures following hemispherectomy and was subsequently found to have residual connections. All these 8 patients subsequently underwent surgery to remove the small residual connection. And following that, we found that about 2/3 of the patients became seizure-free and about 1/3 had improvement in seizures following the repeat surgery. In addition to residual connections, what other potential abnormality can we find on the MRI? So we reviewed all the MRI of patients who had undergone hemispherectomy, and among these patients, we found that 3 patients who underwent hemispherectomy and then subsequently had persistent seizures after hemispherectomy, and the repeat MRI post-hemispherectomy showed hippocampal sclerosis on the good side of the brain. So hippocampal sclerosis is, it represents scarring within the hippocampus. So hippocampus is a structure in the brain that is important for memory. So we found that there was scarring in the hippocampus on the so-called good side of the brain that was not visible on the MRI before the hemispherectomy. So when we review the MRI, we don't just look for residual connections, but we also look at the rest of the images in great details to see whether there are any other potential causes for the recurrent seizures. So I will move on to corpus callosotomy. Corpus callosotomy is a type of surgery to separate the two sides of the brain. This treatment is usually done for a specific type of seizures known as atonic seizures, also known as drop attacks. So with this type of seizures, what happens is that the child will lose muscle strength and then just drop to the ground. Frequently, there's injuries because of the drop attacks. So most cases of corpus callosotomy, there is no residual connections following the surgery. This is the one and only case that I've come across where there is residual connections in the front and the back part of the corpus callosum, and this child had surgery outside of the United States. So this is really rare occurrence. Okay, so let's move on to post-processing of MRI for epilepsy surgery planning. So at our institution, epilepsy surgery planning is really a multidisciplinary teams-based approach, and we work very, very closely together. So the team includes epileptologists, neurosurgeons, neuroradiologists, and neuropsychologists in planning the surgery. So in this presentation, I will just show how we use post-processing of the available clinical MRI and CT scan if it is done to help with surgical planning. So the first case that I brought along is a child with a lesion, i.e. a focal cortical dysplasia behind the motor cortex. So the motor cortex is a critical part of the brain that controls movement. So the lesion is located immediately behind the part of the brain that is critical for motion. So what did we do? So we trace out the lesion, which is outlined in orange or red, and we also do DTI tactography of the corticospinal tract, which is outlined in yellow. So what is the corticospinal tract? So that is the wiring that controls movements. And by showing the relationship of the two structures, i.e. the lesion, how close it is to the wiring that controls movements, this will help in terms of planning the surgery, the approach, how to minimize injury to the corticospinal tract. The post-processed images are then used to guide placement of intracranial EEG electrodes. So intracranial EEG electrodes are electrodes that are placed into the brain itself to try and pinpoint exactly where the seizures start in the brain. So once all the intracranial electrodes have been placed in the brain, typically the child will undergo a CT scan. So what we do is we extract out the location of the electrodes from the CT scan and combine those with the preoperative MRI images so that we can show where each individual intracranial electrodes are located relative to the lesion and relative to the corticospinal tract. So in this case, the lesion is shown in red and the corticospinal tract, i.e. the wiring that controls movement, is in yellow. So this type of data is really helpful for the surgeons and for our epileptologists when they're reviewing the EEG data to determine exactly, where to resect, how big should the resection be. And what is more cool is that we can transfer all this data not just from the software package, and we can move all these images and the post-processed images onto the operating room itself. And the surgeon can use this it's almost like a GPS or roadmap to help them when they are doing the surgery. Okay, let's have a look at another case. So this child had previous brain surgery for another reason not related to epilepsy. So here you can see the hole in the brain related to previous surgery, and there is also a hole in the skull from previous surgery. So in discussion with our neurosurgeons, the information that they want from us are as follows. Firstly, where are the holes in the skull and where is it located relative to the hole in the brain? And the third information that they want to know, where are the blood vessels on the surface of the brain relative to the hole in the brain? Okay, so this is the type of data that we can provide them. So we use the MRI data, we extract out the brain itself to create a cast or a mold of the brain to show where the hole in the brain is located here. We then extract out data on the blood vessels on the surface of the brain and create a cast of the brain and then overlay it onto the mold of the brain. So what you see in red is the blood vessels on the surface of the brain. We also combine the MRI with the CT scan. The CT scan will help us to extract out data on where the skull is located, and we fuse them with the MRI images so that we can show where the hole in the skull is located relative to the hole in the brain and relative to where all the blood vessels is. So this type of information will help the neurosurgeon plan their surgery, which approach they should go, how they should avoid the blood vessels so that there is, minimize bleeding. So these are the type of information that we can use by post-processing the MRI images and the CT images and help our surgeons when they do their planning. So I just want to show it in a kind of different way of looking at it. So here you have the skin, and you can see the scar on the skin from the previous surgery. Let me play the video. So we can then strip off the skin to show the skull, and we can show where the hole in the skull is located. And then gradually we can strip off the skull so that we can see where the hole, so that we can see where the hole in the brain is located. So here is the hole in the brain, and we can also see where the blood vessels are located. So this type of information is incredibly helpful for our neurosurgeons when they plan their surgery, and we can transfer all these post-processed images into the operating room space so that they can use it as a GPS or as a roadmap when they do their surgery. Okay, so to summarize, it is important to identify a lesion on MRI, and we do spend a lot of time and with great details looking through the MRI to see if we can find a lesion. Finding a lesion matters because it will help improve patient outcomes after epilepsy surgery. There are factors that affect the detection of a lesion on MRI. These include the type of lesion, the strength of the magnet, the MRI techniques, and the experience of the radiologist. In this lecture, we then review hemispherectomy, what happens if the child develops recurrent seizures after hemispherectomy. So typically we'll do high-resolution structural MRI and diffusion tensor imaging, and we look for small residual connections that connect the two sides of the brain. And then in the last part of the presentation, we looked at post-processing of images for epilepsy surgery planning. We reviewed how we use structural imaging and also diffusion tensor imaging to show where the critical wiring that controls movements. We can also do it for other critical wiring as well. And all these post-processed images can be transferred to the operating room to help the neurosurgeons as they're doing their surgery. So I just want to emphasize that what we do, we don't do things in isolation. I don't just report MRI. I work very, very closely with the whole epilepsy team, including neurosurgeons, neurologists, nurse practitioners or APNs, the neuropsychologists, EEG techs. Like there's a lot of communications that goes on behind the scene to make sure that everything falls in place and we provide the best care for our patients. Thank you.
Twice we were assured that my son was completely disconnected with diffusion tensor imaging, and twice when the neurosurgeon went back in, he found residual connections in the basal frontal area, which I understand is a difficult disconnect. We had an extremely experienced neuroradiologist at UCLA. What does a parent do when the imaging comes back totally disconnected? How should we advocate for further testing?
Yeah, so I would say if the MRI is high resolution imaging and the diffusion tensor imaging is have also been done, I would say in the vast majority of cases we will be able, based on my experience, we're able to identify residual connections. Is there possibly a situation where there is subtle residual connections that are not identified on MRI? It is possible, I guess, but those residual connections has to be really small because usually the resolution of MRI, I would say 1 millimeters or less than 1 millimeter. So the residual connections has to be below 1 millimeter in thickness, for it to be overlooked on MRI.
I just wanted clarification. When you were talking about the hemispherectomy, is that functional and anatomical hemispherectomy, or what were you referring to when you were talking about hemispherectomy?
The vast majority would be, you mean in the study and the literature review?
Yes.
Oh, I see. Okay. So it is, I have not separated out between functional hemispherectomy versus anatomical hemispherectomy. These days, most people don't do anatomical hemispherectomy as the first surgery. Usually it's a functional hemispherectomy, and if that does not work, then they will consider doing anatomical hemispherectomy. So in terms of the data that was presented, we just kind of combine all of it together.
When I'm looking at my child's MRI report as a lay person, how can I see whether they had which Tesla they had? It doesn't say. Like, it was in a level 4 children's hospital. Do I assume it's a 3? Or is it possible that he could have only been having a 1.5?
I would say most institutions that do high volume epilepsy surgery would do it on 3 Tesla. The exception if there is any contraindications to doing it on 3 Tesla. So in the vast majority of cases, I would say most people would now do the scan on 3 Tesla in kind of level 4
okay,
centers.
So if it doesn't say it, I can kind of assume that it was. Okay. And then if I want him to have more studies, can I just advocate for that? Can I say you've still not found the FCD, but we know it's there? Like, can I just keep saying, please do more?
I think you can, certainly you can advocate. So if the MRI is really high resolution, it's been reviewed in great details, and a lesion is still not found, usually one of those additional tests like magnetoencephalography, PET or SPECT will be done. And that could be used to help guide surgical planning, in particular intracranial EEG planning. So if indeed the MRI has been done with high resolution and still a lesion is not found, I think the alternative, i.e. one of those additional tests should be done. And typically they would request for it. If they don't, you should advocate for it.
He seems to have a dual pathology, so he had a DGONC tumor in the amygdala, but now also seems to have FCD elsewhere, like parietal, but he can't find it. So he's had resection and 2 stereo EEGs. So I'm just kind of wondering where do we go next? I don't want specific for my child, obviously, but I'm just kind of wondering, like, when we've sort of reached kind of the end of what we can do, how much can I say, please do more investigations on my child?
Yeah, I think there is no harm in asking, is there other tests that needs to be done, like, PET or MEG or SPECT scans. So I'm not specifying which particular test because it depends on the expertise and the experience of individual centers. So some centers have more expertise on PET scan, others have more expertise on magnetoencephalography. So, in terms of the specific types of tests, it varies across centers, but certainly one of those tests should be done or should be considered for further evaluation.
My question has to do with those 3 tests. So at the hospital where we're at, she did have a PET scan after a negative MRI. But is it better to do one over the other, like MEG or SPECT, or all of them, or is the PET enough?
Yeah, so it really varies. So it depends on the expertise of centers, because I've worked in Toronto where magnetoencephalography is their kind of real expertise. And there are other centers where PET scan, they do it really, really well. And yet there are other centers that, for them it's the SPECT study that they do it really well. So I wouldn't say, do this particular test or that particular test, but I would say more of one of those tests should be done. If one of those tests is normal or negative, then potentially could consider additional tests. So let's say if magnetoencephalography doesn't yield doesn't show an abnormality, then consider including PET scan. So yeah, so if one test is not helpful, then do consider additional tests.
And then, so if the PET scan didn't come up with something, is that enough? Or do they need to go into more detail, or that will direct them to the EEG, another EEG? Is that what will guide them in the EEG?
Yeah, it varies. If the EEG is really focal and there is an MRI abnormality, usually that will be sufficiently helpful to guide where to place the intracranial EEG. So there's a lot of kind of nuances. If the EEG is not highly specific and the MRI is normal and the PET scan is normal, then perhaps an additional test could be considered. So there's a lot of kind of nuances to it. Any other questions?
Nobody?
I do research in structural and functional neuroimaging, so I'm just curious to know from your perspective, what role you see moving forward for kind of, especially in the case of negative, MRI-negative focal cortical dysplasia, the role of our advancements in things like FreeSurfer and the ability to kind of parcelate the brain and not just kind of look at it with our naked eye, but actually be able to say, oh, we can see differences in cortical thickness and volume, et cetera, in different areas of the brain. What role you see that playing over the next 5 to 10 years, and if you're starting to see any role of those kind of advancements of resources in your practice?
Yeah, so I know there's been a lot of research kind of looking into using machine learning to help identify a lesion, and also using post-processing tools like FreeSurfer to try and identify subtle changes that may not be as visible or easily overlooked on just by visualizing the MRI with naked eye. So my experience is that so far those tools are not ready for clinical use. Could it be that 5 to 10 years from now, when there are more advances in all these types of tools or post-processing, it is possible? But based on my current experience, and I've done some research on this area as well, I still, like, because of my experience, I'm able to detect more lesions than the current post-processing tools.
Yeah, I was interested in what might motivate a callosotomy if they're still done versus a functional hemispheric.
Corpus callosotomy is only done for patients with drop attacks or atonic seizures. It's more of a treatment to treat a specific type of seizures. If the child, and frequently the child will have other types of seizures, it doesn't treat those type of seizures. So there is a difference in that regard, whereas hemispherectomy is typically done in patients with unilateral abnormality, both on MRI and on EEG. Whereas with corpus callosotomy, the treatment, the drop attacks you may still have seizures on both sides of the brain, but it's used to treat a very specific type of seizures. So there's a difference there.